Okay, no intro music this time, guys. Chapter 11, Heart Block Rhythms. This one's actually kind of fun, I think. Now, I'm going to give you guys a few little hints and tips and things when we get to a certain point to help distinguish these heart blocks, and I hope that you'll take these to heart. Let me share with you. When I went through EKG class, I got extremely. We had all the cardiology and pharmacology all in one thing. So we were learning ACLS and rhythms and all of that at one point, all at one time. So I learned blocks, but I was not good at it, and I was extremely intimidated by it. And I hate to say this, but it was many years after learning it and becoming a paramedic and operating as a paramedic and all those things at fairly high level that I finally figured out a quick, easy, down and dirty way to figure out these blocks. Now, if you choose to use it or not, that's completely up to you, but I'm telling you, for me, this kind of just changed everything looking at this one very small thing about these blocks. And we'll get into that in a little bit. But starting off with our blocks, we're talking about a lot of different things. So this is just reminders. Site of origin. Let's get that off there. SA node generates the impulses. We know that this is normal, and then it goes all the way down. But if there's a blockage or a delay, then the impulse will be a partial, an incomplete, or a complete block. And what these are called is, these guys are called heart blocks, these rhythms. So they can either be permanent or transient, minor or significant. So sometimes you may have a patient, especially like when they're reperfusion rhythm. So say if you're with somebody that had just gotten over an MI, or if you're transferring someone that had thrombolytics given to them and their heart's starting to reperfuse, you'll see all kinds of wacky stuff. So heart blocks, you may get a heart block for 15, 20 seconds, just a few beats even, and then it moves on to another rhythm. So that's what we mean by transient, or it can become permanent. As you can imagine, if they have a high-level heart block and it's permanent, then they're probably going to get a permanent pacemaker. But the thing to think about with this is patient assessment. So when we hear the word heart block, that's kind of an intimidating word, or it should be, and we start thinking, man, this guy must be sick. But as you'll find out, there's some heart blocks that really aren't that big of a deal. Obviously, it's not optimal. If you want to be the most optimal person in the world, this is not the way to do it. So we know, once again, all of the same stuff. This SA node goes through the internodal pathways, AV node to the bundle of his right and left bundle branches, into finally the Purkinje fibers into the muscles of the ventricle. I'm not going to go over that again. So, starting off, first degree AV block. So this is the most usual form. Most people are unaware that they even have this. They're not complaining of anything. I had a friend who was a marathon runner, and we did an EKG on him when we were in paramedic class. Turned out he had a first degree block. He went and saw somebody. The docs were not concerned about it at all. So it had never caused him a problem. And so this is just one of the most, as you see, the most usual form. And what it does, as you can see here, is results from excessive conduction delay in the AV node. Remember, when we talk about the AV node, you have a delay here when it travels through here. Well, it's just a little bit longer of a delay than what's normal. So what you do is you get this normal PR interval that will be prolonged. So remember, our normal is 0.12 to 0.2, and it's actually going to be longer than that. Really not a dysrhythmia, and it only indicates a delay rather than a definite block. So it's not a big deal. As you see here, it can be seen in young athletes. And for him, they were never sure what had caused it, but you can see there's some medications that can cause it. So as we'll see when we look at this block, the only thing different about this is that they have this prolonged PR interval. That's the only thing different. So the PR interval is greater than 0.20 seconds. Remember, it was 0.12 to 0.2 is our normal, within normal limits for a PR interval. So The rate, based on the rate of the underlying rhythm, is usually not affected. The rhythm should be regular. There should be a P wave before each and every QRS. They should be upright and uniform. And once again, here is our difference. It's greater than 0.2. So looking at a rhythm, we can see here, let's go through our regular diagnosis. So we'll start here. We say 300, 150, 175, probably a heart rate of about 70. We can confirm it. 1, 2, 3, 4, 5, 6, 7, and 70. So that's our rate. Our rhythm looks pretty normal. Looks pretty regular rather. So, but we can look to see. So we can find this one. We're looking at 1, 2, 3, 4, close to half. 1, 2, 3, 4. We're right in there. It's pretty regular. And remember, they're not always going to match up. But if we were to get paper out and start marking these guys off every time, and we marched it down, we would see that they're within normal limits. So we move on to our P waves. So we do have a P wave that precedes every QRS, and it is normal, not normal, but it is upright and uniform. And then we look for a PR interval, and that's where we find the difference. Is we should have a PR, probably a P wave right around in here, but we see this is our PR interval here. So as you can see, that's a pretty long and extended PR interval. So we're looking at what, 0.24 probably is what we're thinking that might be. So and then our QRS is pretty normal. So 0.24. So it's the only thing out of this is different. It would be a sinus rhythm, but it has a first degree block. So we're going to diagnose this as a first degree block. Not a sinus rhythm with a first degree block, and you might see that sometimes, but this is just going to be a first degree block. Moving on, second degree heart block type 1. So this is less serious than the next one that we're going to talk about. And what you see here is the key word is progressive, meaning, think about progressive, it continues on and gets bigger, right? So the progressive delay of the electrical impulse at the AV node. So what happens is this PR interval continues to increase until the impulse is dropped. So what we'll have is that that PR interval it might be within normal limits at the beginning. The next one it lengthens, right? It's progressive. The delay is progressive, and it gets longer and longer and longer until it eventually drops. So the pattern is repetitive throughout the duration. So when we look at the rhythm, you might call that regularly irregular, or you could call it irregularly regular. But it is irregular because we're going to be dropping a beat, but it happens regularly. So that's how we end up getting into that. So what you can see is that one term, we call this second degree type 1, Mobitz type 1, or you're also going to hear it called a Winky-Bach. My understanding of this is there was a Dr. Winky-Bach. He was a cardiologist, and I don't remember what the years were, but what's amazing is, if this story is true, is that Dr. Winky-Bach discovered this phenomenon with nothing but his stethoscope. So he was able to hear and distinguish that there was a difference in a PR interval of when valves were opening and the atria was contracting and the delay before the ventricles contracted. He realized there was a progressive delay that happened throughout there, and then diagnosed, and then it was just called the Winky-Bach phenomenon. So one thing I'll tell you to that you might think about remembering is going, gone. So type 1, just delayed. Now we move on to second degree type 1. Or not type 1. I'm sorry, I said type 1. I meant first degree block is just delayed. Now we move on to second degree type 1, and that's a Winky-Bach, or you can also just remember going, gone. So atrial rhythm is regular, the ventricular rhythm is irregular because it does eventually drop it, right? As well as you have that lengthening PR interval. So let's take a look at one, and we'll start right here. We'll move left to right. So we're going to start on our first one. we're going to, let's look for a rate, which it's irregular. So with it being irregular, it's easier to just count our beats, which would be 60. But our underlying rhythm, if we were to determine that, probably this one would be the easiest. So we're looking at about 3, 151, right around 75. So our P waves, we know that our when we look for rhythm, that it's irregular, right? We see a lot of weird kind of stuff going on. We look for P waves. They are there is a P wave. It's upright, but there's not one before every QRS because we have a QRS missing here, right? So when we say going, going, gone, here's normal, and then going, going. You see how it's lengthening, and then you look here, and there should be one here, right? So gone. Now, it doesn't have to be going, going, gone. It doesn't mean it has to be lengthened 2 times before it drops. Sometimes it might be 3 times. It can vary. But it's just the thought of going, going, gone because it grows. It becomes delayed more each time before that impulse is actually dropped. So looking at it again, we see that here's normal. We have a delay, and then we have a drop beat. We should have another QRS right here. So normal, delay, and another drop beat. So the whole key to this is that there is a drop beat, and it's progressive. One last one. So we see we have normal here. See how it's lengthening, and then this one is lengthening. It just keeps getting longer, and then, wow, got one missing right here. So going, going, gone. Now, second degree AV block, Mobitz type 2. This is a little bit more serious, and a lot of times this can, as you read here, can progress into a third degree heart block, which is really bad. And so what it's telling us is this occurs when there is an intermittent interruption of conduction. So remember, intermittent, just kind of off and on, right? So if we have that interruption of conduction and it's off and on, we might see things that are missing, right? So the SA node is generating electrical impulses at a regular rate, and you should note that the P waves occur in a regular pattern across the EKG strip. The problem is, as we see here, some P waves are not followed by a QRS complex. So intermittently, they're all over the place, right? They're missing. So what happens is you have this impulse becomes blocked, gets blocked, and the AV node, remember, is that gatekeeper to the ventricles. I think I've mentioned that in the past. And what it does is it opens and closes at these regular intervals, and if things don't pass through, by the time it shuts down, it's not gonna get through, right? So what happens is no QRS complex is produced. So you might have you would have a P wave, but you would not have a QRS to match up to it. The ratio may vary, or it may be constant. So it may be different. Sometimes you might have 2 to 1 or 3 to 1, talking about P waves to QRSs. So the ratio, as you can see, 2 to 1, 3 to 1, 4 to 1. And then sometimes it can be greater than 0.12 as well, depending. But remember that it's drop beats, and so that's what is going to make it different. So PR intervals are regular for the conducted beats, and that's going to be the big point here, is the PR interval is regular. When we look at that beat, that we have a complete beat, it's regular. So the atrial rhythm is regular, the ventricular rhythm is irregular because it is all over the place, and you have those non-conducted or those intermittent beats. So it's going to be irregularly irregular because it's just all over the place. So associated with an MI, septal wall necrosis, which sounds bad, doesn't it? Within the septal wall of the heart, it's actually become necrotic, probably associated with that MI that they talked about having. So really a lot of this depends upon if they're going to be symptomatic or not, is going to be their ventricular rate, because the ventricular rate is what's kind of important because it's what's actually creating and producing cardiac output. So when we look at our facts about second degree AV block Mobitz type 2, we see the rate, atrial rate is usually regular. Ventricular rate, though, can be bradycardic because it has those drop beats, right? So as you can imagine, 2 to 1 is a lot better than 4 to 1 because 4 to 1 means you have 4 P waves to every 1 QRS, reminding yourself that those QRSs is the ventricular contraction. So obviously you're not, and you say you have a rate of 80, well, atrially, but 20 in the ventricle, so you have a perfusing rate of 20. So you can imagine you have a really big time decreased cardiac output. So the rhythm, atrial rhythm is regular, ventricular rhythm is irregular. Some P waves are not followed by QRS, but once again, constant for conducted beats. The PR interval is constant. So let's take a look at this. So we see we have these drop beats here, but here's what we're talking about, okay? That PR interval, it's constant. It matches. Now it's a drop beat here. That PR interval, though, is constant, okay? Remember, our first degree block was just lengthened, right? We'll just draw this longer line, meaning it's lengthened. The second degree, type 1, is going, gone, right? So it's lengthening as it goes, and then you have a space, and then it's this, and it's that, and it's this, and this space. Well, now we're in second degree type 2. PR interval is constant whenever there is a P to QRS. When it's not a QRS, obviously it's not going to be constant, right? Once again, let's take a look here. So they keep wanting to do whatever that is, but we're not going to do it. So looking at our rate and our rhythm and all of that, our rate, I mean, we're in the 40s, right? I mean, that's not a good rate. So we can expect that they're going to be probably kind of sick, bad cardiac output, maybe a bad blood pressure, color looks kind of sucky, maybe some chest pain, hypoxia, who knows, all that stuff that goes on with these sick people. So our rate's going to be somewhere around 40. Our rhythm is, I would call that all over the place, right? So just probably, going to be irregular is what we probably call that, at least ventricularly irregular. The atria is very regular. Our P waves, they are present and they are all accounted for and they are upright and uniform. But the PR interval is constant when they are associated. So we don't have one here, so it's obviously not constant. And then QRS looks fine. So once again, it is this is the key to Mobitz type 2. That PR interval is constant. Okay, let's go ahead and look at this one more time. So once again, we didn't take a look at that actually. Hang on. So here we have 1, 2, 3. So this is 3 to 1. Okay, so Mobitz type 2 with 3 to 1 conduction ratio. If you chose to say the conduction ratio, that's up to you. You may see that on a question, so make sure that you're aware of what it is, or if somebody asks you that question. But more than likely, we're probably not going to do the conduction ratio. The higher, though, as you can imagine, 2 to 1 is not as good as 1 to 1, right? 3 to 1 is you can kind of think of sicker. As we get into 4 to 1, you're going to have a lot less perfusing beats. So, looking again, our PR interval, let's just start there because we're talking about blocks. PR interval is constant. I'm going to ask you to remember that. PR interval is constant. So when we go through our rules for this, our rate, we're talking about, what is that, 60-ish? Our rhythm, the atrial rate is very regular. Right? This is very regular. It just keeps on marching right on out. Problem is, we're missing QRSs. So the ventricular rate here, it is regular, but it's not where it's supposed to be because we should have a QRS associated here with this P wave. So the ventricular rate is regular, but it's only because we have a 2 to 1 ratio the entire time. P waves, we have P waves that are not followed by the QRSs, so that tells us there's some type of block. And we have that constant PR interval. That tells us right there that it is a Mobitz type 2, or just second degree type 2. Now, third degree, most serious. This is really sick people. This is the step before the old asystole. And I can tell you that's not good. So if you're unaware of that, because it's very slow, ineffective when we talk about the ventricular rate. So once again, we talk about cardiac output, very minimal cardiac output, and complete heart block is often referred to as a lethal dysrhythmia. So the atria and ventricles are completely blocked and separated. They beat independently of each other. And the SA node fires, though, it's at 60 to 100. Problem is, these two guys aren't talking to each other, okay? So that's part of the problem. You remember that atria has to fire off, and then it allows for some filling into the ventricles, and then the ventricles fire off. You have some passive refilling going on at the same time, but one is helping out the other is helping out the other. So it's just this constant kind of dance of things working together. Well, this way you have the atria going off, and then maybe 2 seconds later the ventricle goes off. Obviously that's going to be a real problem. So the ventricles are paced by an escaped pacemaker, so junctional or even in the ventricles. So sometimes you'll see a really bad rate of that, like 20 to 40, talking about ventricular rate. So sometimes you might hear AV disassociation. If you remember when we talked about drugs, that disassociation was the two didn't really talk well together. You know, you don't really remember much. Reality is not associated with the patient. So that's what we're talking about here. The atria and the ventricles, they're completely talking crazy to each other. So they beat independently. Here's the other point. PR intervals will be variable in length. So they are going to be irregularly irregular. Now, let's take a quick little review. First degree block, lengthened. Second degree type 1 or Winky block, going, gone. So regularly irregular. Mobitz type 2, PR interval was constant. Third degree, all over the place. They're not associated. PR interval is not associated with anything. So this, I created a little thing that I'll show you here in a second, but this is the key to knowing your blocks. Just my opinion. There's probably somebody out there that can tell you something completely different, but what I'm going to tell you is this. These are the keys to getting your blocks, and it makes it extremely simple. So third degree atrial rate, usually 60 to 100, pretty normal, right? But the ventricular rate, that's based on the site of the escape pacemaker. So anywhere from 20 to 40, maybe even up to 50 or 60. But what is the rhythm? Atrial rhythm is regular. Ventricular rhythm is regular. Just happens to be that those guys aren't talking to each other. So, before where we talked about that irritability, kind of like that. Except everybody's so irritable, they're not even talking to each other. So the P wave, no relationship to the QRS. Of course, you do have your P waves, but the PR interval, totally variable, no pattern. Remember, up to this point, everything else has a pattern. It's either lengthened, it's either going, gone, but there's still a pattern there, right? It's lengthening, it's progressing as it goes. Or type 2, you have that PR interval that's constant. Whenever it's there, it's constant. But here we have nothing. It's just all over the place. So we see here, we could say right off the bat, when we just, let's say we don't have that part, we're just glancing at this, we might think first degree block, because that's a lengthened PR interval. But then, whoops, we got a drop beat here. So now, maybe we think, okay, maybe it's Mobitz type 2, so I'm going to look for PR intervals. But the PR interval is completely different here. And then look at this PR interval to here. So as you can see, it is wacky and all over the place. So when we go back to our rules, our atrial rate's usually 60 to 100. So when we talk about rate, atrial, that's what I'd say was probably within that limits, right? So 3, 151, that's going to be 75, so that's probably close to 80. Ventricularly, though, we're looking at what? 30s, right? So if you were to do your 300 method, we'll get way below the 50s and 40s. So, and then we're going to look for our rhythm. Well, the atria is very regular. The ventricular rate, when you look at it, though, is regular as well. It's just these jokers aren't matched up together. Then our P waves are upright, but the problem is there's really no relationship between the P wave to the QRS. QRS is a little bit wide. As you can imagine, we have some ventricular pacing going on. Let's take a look at another one. So once again, Look at this PR interval here. Look at this PR interval here. Not constant, not lengthening, not progressing, none of that. So it's just all over the place. Once again, starting with our, we have what appears to start off with a normal beat here, but then you've got a P wave that's buried in your QRS here, kind of buried in your T wave. So here's a P wave, and then you have this huge PR interval, and then here's a P wave, and it's this is actually in reverse, right, of what we've seen with Winky Bach. It's actually getting shorter. So rather than going, gone, it's gone, going, which there's no true rhythm like that. So once again, clinical significance, first degree heart block, in and of itself, little to no significance. So you just treat the patient. Second degree type 1, I've never seen anybody that's been in Winky Bach that's been sick. So usually it just kind of comes and goes. Not often that you see it, or at least that I have. Type 2, if the pattern demonstrates a rapid rate and frequently drop beats, cardiac output can be compromised, as you can imagine, depending upon the ratio, right, the conduction ratio. So if it's 3-to-1, 4-to-1, we're not getting a lot of ventricular beats in there, so we would expect some decreased output. And a big key to this is this needs to be a red flag for advancing degrees of heart block. So this can progress to third degree, so frequency of the drop beats is a major concern when we're talking about type 2. And in third degree, like we said, nobody's talking to each other. So if the QRS complexes are narrow and the patient is asymptomatic, AV junction is most likely serving as the pacemaker site. At minimum, you'd want to put your patches on them, in my opinion, and be prepared to pace. Now, they're going to be bradycardic, but remember where your where atropine works within the heart. Go and review that. I'm not going to do all the work for you, but I want you to go review and see where the heart, what atropine works on in the heart, and then figure out why it would not be a good drug for a third degree heart block. Now, when we do our bradycardic algorithm, we still typically start with atropine, but just understand why it may or may not work here, because you're being paced in a particular place of the heart, in a particular portion or pacemaker site, and the drug works in a completely different portion of the heart. So if they're exhibiting signs and symptoms, the QRS complexes are wide, you may want to just move right on to TCP or transcutaneous pacing. Look at your patient, talk to them, and figure out if they're sick or not. Now, hang on, let me let's go to here. So once again, we talked about those few things, that PR interval, okay? First degree block is constant and lengthened, right? Longer than normal, longer than 0.12 to 0.2. Second degree type 1 is regularly irregular, so going, gone, or however many goings it needs. Second degree type 2, so this is Winky Bach, remember. This is Mobitz type 2, and the PR interval is constant. And then we go on down to third degree block, and it's just all over the place. There is no PR interval to speak of because it's just all over the place. There's no, well, there is a PR interval, obviously. Every time there's a P wave and a QRS, there's a PR interval. But there's no system built. You know, it's not being constant. It's not lengthening. It's not doing all that. It's just erratic and all over the place. Okay, I had to stop and take a look at something. Let's take a look here at a couple of strips. So this one kind of threw me off for a second. We're kind of ugly looking. But at first, and when I first glanced at it, I thought it was a Mobitz type 1, or a second degree block type 1, I'm sorry, Winky Bach. Because I looked here and I saw this and I saw this, and it looks like maybe we have a drop beat. But when you look and you look at your ventricular rate, we see that the ventricular rate is very regular, so we do not have any drop beats. So considering when we look at them, we see our PR intervals, because we have a rate of, ventricularly, we have a rate of, hang on, let me get some of this junk. I know you don't, it's not your way, you can't see it. So 3, 150, 175, 60, less than 60. ventricular rate of around 60. Rhythm, it looks to be pretty regular ventricularly anyways. Atrially, probably as well. It just happens to be in here. That's why we see these weird little ups and downs and little mountaintops and all that, because that P waves and buried potentially within there as well. So I believe that you would march this out if you're really able to see where all the P waves were. It just completely disorganized though. So we're going to call that a third degree block. Okay, looking at our second strip. So our rate, we're looking at 150, 175, around 65 is our rate. Our rhythm, ventricularly, is very regularly. Atrially, is as well. Looks to be regular as well. So and we look at our PR interval. P waves are upright. Look at our PR interval. It looks lengthened. So let's go with a first degree block. This is the thing that kind of messed me up when I first glanced at it, because it's a repeat of a rhythm we just looked at. So let's take a look here. So obviously we have something weird going on here when we talk about rhythm or rate. We got what, around 70s. We have a PR interval, looks pretty normal here, lengthening, and then a drop beat here, lengthening, drop beat. So I would probably call this a second degree Mobitz type 1 or a Winky-Bach, going, gone. This one's a little harder to differentiate. So here's a P wave right here. So rate-wise, we have what, 3 around in the 60s. Everything looks pretty normal other than this PR interval, right? So we would probably call that a first degree block. Oh my. Now we're talking about a mess. So there is no correlation. We see a little PR interval here, but it's longer here. So we know there's no constant PR interval whatsoever. So a third degree block, as well as, like, we have 2 beats in a 6-second strip. So we're talking about in the 20s. This person's going to be sick. So I'm going to let you guys finish the rest of these Hartbach rhythms. Let me go back to my notes. So remember, I've already hit this so many times, but first degree PR interval is constant and lengthened, greater than 0.20. Second degree type 1 or Winky-Bach, regularly irregular, so it's going, gone. The key is, that's irregular, but it's regularly irregular. So second degree type 2, it's constant. You have a PR interval that's constant. Third degree is just all over the place and chaotic. So something to remember is Mobitz type 1 or second degree type 1 is the same as Winky-Bach. So we have a couple of different names there. Trying to think if there's anything else. You might hear complete Hartbach as opposed to third degree Hartbach. And remember, that's when nobody's really talking to each other. I'm going to post up a funny little poem here in a little bit that you can look at, and it kind of explains the differences between blocks if you were to put that to a nice little tune in your head. And I think that's about it, man. So you guys enjoy. That's been Hartbach introducing you guys to Hartbach rhythms.